This is Understanding Neck Pain, and in this video we're going to talk about facet and bony changes. Keep in mind, this is one part of a multi-part series, so if you haven't already, go back, watch the other parts so you can get the full appreciation of how this works. Now, the reason we do this is so that you can be empowered with knowledge, so you can make quality decisions, so you can get to the root cause of your problem and find a solution. Thanks for joining us. My name is Dr. Todd Pickman. I'm the clinic director here at Gonstead Spine and Wellness in Meridian, Idaho. And on this video, we're going to be talking about facet and bony changes and how that pertains to understanding your neck pain so you can get to the bottom of this once and for all. Again, this is one part of a multi-part series. If you haven't seen the other videos yet, go back, watch those. There's a ton of great information. Some of the stuff I'm going to talk about here builds on what we talk about in previous videos, so make sure you check that out. And on this one, we're going to really start off with this word arthritis that so many of us have heard about. In the context of what we're talking about here, when we talk about arthritis, this is a mechanical joint problem. It's called osteoarthritis, degenerative arthritis. There are other types of arthritis that have to do with autoimmune, like the immune system attacking your joints, various things with foods that you eat, and other aspects that are outside just the pure mechanics. But for the sake of this discussion, we're going to really focus in on the mechanical portion of this, because that is the majority cause of arthritis when it comes to the spine and when it comes to the facet joints. So if you look at this diagram, you can see this is the spine's facing this direction, this way, and then we have the spinous processes back here, and those are the bony prominence that if you feel on the back of your spine, you can feel that little point. Just deep to the spinous process, you have these joints on both sides of the spine called the facet joints. They are guiding joints. The function of them is to prevent the joint from moving too much in a bad direction. It's a synovial joint, meaning it has a capsule around it. There is synovial fluid inside of there, and that helps lubricate the joint, and it's a closed environment. There's all this fibrous tissue around there. And this can be a source of pain when things get messed up, when things get inflamed. So let's dive into that once we understand a little bit more of the function. These are the hinges of the spine. They guide motion. There's all kinds of motions here you can see on this picture. There's flexion, where you bend the head down. There's extension, where you bend the head back. Also, rotation is another thing. When you rotate side to side, those facet joints bend side to side. They prevent those vertebrae from sliding in the wrong way so it doesn't impede or hurt a nerve or spinal cord. Because remember, the spine is like armor that protects the most delicate tissue in our body, which is nerve tissue. Our central nervous system, our spinal cord, is protected by the bones in the spine. The brain is where it all starts, but that's protected by a skull. The skull really doesn't move. All these individual segments in the spine, they do move, and that's so that we can actually function and go through certain activities throughout the day. But the downside to that is that when things go wrong, the movement of those joints or the misalignment of those joints or destruction of those joints can affect the content of those bones and joints, which is, again, the delicate nerve tissue. And then there's lateral bending, which is side to side. So again, flexion, extension, rotation, lateral flexion, lateral bending. The facets help with stability and support. So they help hold things upright alongside with the disc. Now we're just talking about the joints. There's also ligaments, which connect bone to bone, and then there's muscle, but we're not talking about that on this one as much. And then we look here and you can see various loads in the spine. So this diagram is showing like downward compressive force. Mostly that compressive force is going to be absorbed by the disc. But the main thing to understand as far as how these joints work together, there are two facets and one disc at every single vertebra in the spine, minus the very atypical upper cervical C1 on C2. So atlas and axis C1 and C2 are a little bit different. Again, we cover this in a previous talk as we're talking about understanding your neck pain, where we dive into the anatomy. For most of these joints in the spine, you have two facets, one disc. The facets take on approximately a third of the load each. So it's a third for one facet, a third for the other, and approximately a third for the disc. In this diagram, again, it's showing that, for example, if there's an anterior shear, so like if the vertebra is coming forward, it shears on the disc, that facet joint capsule, it's stretching, it's distracting that joint. And so as we get into some of the x-rays and showing you what can go wrong with the facets, you can see just quite logically when there's abnormal position of those joints or abnormal stressors, that will cause damage to the joints. So like in the case of a proper cervical curve, we're supposed to have a nice forward cervical curve. When you lose the curve in the neck because of a whiplash type of injury, this is something, again, we've covered in previous videos, but we'll go over these things over and over again as we go through the topics, because we're dissecting out each individual topic and applying it to the big picture. But what happens is that these different postural positions can affect the joints and cause them to break down and create pain. And so ultimately, posture is one of the important pieces to look at here. Again, covered in a previous video, the alignment, the posture of the spine is going to directly affect the way that these different joints are loaded. The facet joint is going to be loaded in the most proper way when you have a nice forward cervical curve. When you have a reverse cervical curve or a big forward head translation, that will load the facet in an abnormal way. Load distribution, that's one of the things that the facets do. Again, the facets protect the spinal cord and nerves as well. This is showing the actual vertebra way up here in the front. And then this whole space in the middle here is the spinal cord. Now, the spinal cord isn't really segmented like this. It's one tube. This is showing which part of the spinal cord matches up with each level of the spine. And then there's a spinal nerve root that comes out on each side of the spine. And then on both sides of the spinal cord, there's this space, and that space is where there is cerebral spinal fluid. Essentially, the spinal cord is being suspended in this fluid. One of the reasons is because that serves as protection for the spinal cord. It is suspended in this fluid. How facets get injured, let's say you're sitting behind a computer and you have bad posture and your head is flexed forward, or even worse, really, your head is shifted forward like this. As your head translates forward, the facets are going to jam down, and there's going to be more load distribution on the facets as the disc opens up, and that is going to cause facet injury over time. Excessive loading. So here we see tech neck. The head is bent forward looking at a cell phone or device in this flexed position. That will distract the facets if those facet joints are loaded or distracted excessively. That can cause a problem. And then a whiplash type of injury. That's a very common way to distort the shape and posture of the cervical curve and damage the facets. When you are in a car crash, for example, and you're shoved forward and you rapidly extend, and then the vehicle is pushed, comes to a stop, and then you come forward and then you flex. That compresses the facets first, and then it stretches and deranges the facet and all the ligaments around there in that flexion moment. This doesn't have to happen only in a car accident. This can be like a slip and fall. This can be sports injuries. There's multiple things that can cause a whiplash, not just a car crash. Repetitive stresses can also cause facet and boney changes. And the boney changes part of this is that bone remodels to stress. That's called Wolff's Law. This is a thing that we learn in bone physiology. Bone remodels due to abnormal stress and load. Bone will actually change its shape over time in response, trying to compensate for abnormal load. So if you can remove the abnormal load, you can keep the bones more pristine and shaped the way they're supposed to. The reason you don't want abnormal bony changes to happen in the spine, for example, is because it can impede how the joint moves. It can create pain. And even worse off, those bony changes, the bone can go in places you don't want it to go, meaning it could go into the spinal canal, into the spinal cord, or into the IVF, which is the intervertebral foramen, which is where those spinal nerves come out in between every vertebra in the spine, and it can actually have bone straight on the nerve. So bony changes are not good. This is something that I'll show you a diagram here in a second of how the facets and the spine in general degenerates. Here we go. Here's the picture. And on this one here, the spine is facing this direction. So spinal cord's back here, and you have bone, disc, bone, this herniated disc right here. And look at the bone, how the bone has changed over time. And you have this osteophyte, or technically in the spine, it's called a spondylophyte. It's a bone spur. When the bone spur goes out to the front, It's not that big of a deal most of the time because you don't have nerve structures out here. You actually have this big old ligament in the front called the anterior longitudinal ligament, and it pretty much holds that intact and it doesn't disturb other structures unless it gets really big. If it gets really big in the front here, it can actually cause problems swallowing. In some cases, that requires a surgical intervention to go in through the front of the neck to then cut that bony spur out of the way so that the esophagus, which is the tube that when you eat food and you swallow, that's what connects your mouth to your stomach. That's what would cause a swallowing issue, is this abnormal bone growth pushing into the esophagus. But back here, if the bone spur starts to come back here like it's showing, that's when you're in trouble, because there's not a whole lot you can do to change the mechanics of that. It's just physical bone pushing on nerve. And typically at this point, if it's causing neurological distress, that's going to be a surgical case. And in those cases, usually what will happen is it'll be an anterior approach. So what will happen is the surgeon will cut through the front of the neck and they will remove the disc through the front, and then they will go and they will remove these little bone spurs back here. That's something that I've actually witnessed multiple times. I've been in the operating room, like we've talked about in previous videos, and there's this handheld tool. It's like a long little grabber, and it has this little pincher on the front, and it just bites off chunks of bone in the front. So they essentially reach that through the neck all the way to the back of the spine, right in front of the spinal cord, very delicate area, and they're just nibbling off little chunks of bone so that it's smooth in the back here. And then they remove the cause of the problem, but the problem is, to get there, they had to cut through the entire disc to get there. So now that joint is destabilized, and there's two options at that point. They either do a fusion, where they put a plate in the front of the spine with some screws, or they'll do what's called a joint arthroplasty if the person is a candidate for that. And that means an artificial disc or artificial joint replacement. There are benefits to that because then you can maintain proper movement. However, if the facet joints in the back are severely degenerated and creating lots and lots of pain with movement, the patient's going to wake up and still have that chronic pain. In those cases, the surgeon will often recommend fusing the joint, which then stops the joint from moving forever, and that fixes your issue, so to speak, in that moment. But then the problem is you have what's called adjacent joint disease. So that means that the joint above and the joint below is going to have to move excessively to make up for that lost motion in the segment that's fused. And then over time, those other joints are going to wear out prematurely. Now, degeneration is common in people over 40 years old. It worsens with age. That's what the stats show. But the reason that is because someone has a trauma, you have abnormal mechanics, and then you've added time to the equation. So it's not like the spine has to degenerate or joints have to degenerate as we progress in age, but it happens when there's trauma, there's abnormal mechanics, and then you add years to that situation. So if you can improve the mechanics as quickly as possible and then do things to support healthy mechanics and healthy joint function, you can defy this statement that it has to worsen with age. It doesn't have to. There's patients we see that they'll have perfectly normal discs and facet joints and everything in their spine, and then they have other joints that are just destroyed. And sometimes we will ask them a thought-provoking question. We'll say, okay, your doctor told you this is because of your age, right? Okay. How old is the joint that is beat up and broken down? And they'll say 50 years old if they're 50. Okay, great. 50 years old. Okay, now how old is this other joint that's in really great shape? Oh, it's 50 years old as well. Okay, so both these joints are the same age. So obviously it's not age that caused this. So what is it? And again, it's trauma, changes the mechanics of the joint, and then you add time to the equation. So if you can improve mechanics and do that as quickly as possible and not allow abnormal stresses and loads to set in, you can prevent these things from breaking down. This is a CT scan. It's showing here again, it says osteophytes, bone spurs. You know, it's funny, in school we learned osteophytes, when you talk about in the spine, is actually the wrong terminology. It's called a spondylophyte. So every time I see that, I'm like, ugh, spondylophyte, but it's pretty much accepted. Everyone calls them osteophytes as well. So this is showing a bone spur. In this case, it's going into the spot you don't want it to go into, because this right here in between, that's the spinal canal. That's going into the space where there's a spinal cord or spinal nerve root. You do not want the bone spur to go there, but you cannot control where the bone spur goes. So the best case is try to prevent the stuff that causes the joint from degenerating in the first place, meaning you want proper movement. That's what specific chiropractic care is really good for, is ensuring proper motion in the joints. You want proper alignment and curve. That's what curve correction, like chiropractic biophysics, is really good for. And you want good movement patterns. You want everything to be moving in a functional manner. When you go from point A to point B, that's what assessing and correcting functional movement patterns is. So guess what? At Gonstead Spine and Wellness, we address the segment, the posture, the movement. We're addressing this stuff to try to actually get to the root cause of the problem. This next one is called sclerotogenous referral pattern. This is interesting because there are different pain patterns that are very predictable that are based on not the nerve necessarily being pinched, not the disc herniating and compressing the nerve, but from the facet itself being irritated at that joint level, causing these sorts of sweeping patterns of pain. And it's spelled out here. So it's showing more like the upper neck can go like behind the ear, and then the upper neck area here, and then a little bit lower side of the neck, and then lower to the side of the neck, and then even into the trap area and shoulder, and then down even into the shoulder blade. Now, these patterns right here are caused from the facet joint. And when we adjust a joint in the spine in the Gonstead method, we are trying to affect the misalignment as it pertains to the disc. However, the facets are along for the ride. When we adjust the joint, we're affecting the mechanics of the disc, but we are absolutely also affecting those facets. We are affecting all these structures when we are able to improve the mechanics of a joint with a specific chiropractic adjustment. So how do you diagnose a facet problem or bony changes of the facet? Well, one is you take x-rays. So you take an x-ray, you can assess the border of each bone, the shape of each bone, and there's some different views that can be taken. And then next, you look at the location of the pain. You look at those sclerotogenous patterns. You look at if someone's, pointing kind of superficially, it hurts right here. You're looking at when someone bends to one side and they say, I feel like pinching on the side, or it's hurting a muscle on the side. Well, if you bend into the side and you feel like a pinching or pain as you bend into the side, that's usually joint impingement. That means the joint is not moving properly. It's not gliding and sliding properly. It's getting locked up. So that's impingement on the side of bend. If you bend this way and you feel a pain on the opposite side, you're usually not going to have pain with distraction of the joint as much. You can, but that's usually more of a muscular issue on the opposite side. So on the side that you're bending into, pain is impingement. On the stretched out side, usually typically a muscle. Now over here, we're seeing again CT scan, and this is showing bony changes. That's one of the ways to really diagnose what's going on with the facet. And these are things that are also seen on MRI. That's typically what you'll see these on. It's less common to go and have a CT scan ordered when you're having pain in the spine or referred pain somewhere, going into muscles and parts of the back, or potentially numbness or tingling into the arm. When a doctor is suspecting a nerve compression or disc issue, they'll usually order a MRI, not a CT scan. CT is going to look at bone in different planes a lot better. MRI is going to look more at soft tissue. Okay, and then moving on. This right here is digital motion x-ray. This is a very unique type of imaging. On the left and the right, this is just a plain film x-ray. This is flexion, bending the head down, extension, bending the head back. There's some marking on here that's done with a very specific type of software that we use that allows us to measure down to the fraction of a millimeter how far a bone is sliding forward or backwards. This is something we covered in the previous video talking about ligament instability, when we're looking to see if ligaments have stretched or torn and allowed excessive motion in the spine. Now in the middle here, we're going to show the actual video animation of this moving. And this takes 30 frames per second with digital motion x-ray, so we can freeze frame it. We can look at all the movements and we can see which things are moving too much, too little. It gives us an idea of what should be focused on adjusting wise or exercises. But also as you're bending forward and it stretches apart too much, this will give us feedback as far as if there's likely a damage to the facet capsule. The capsular ligament is what connects one part of the facet to the next. And I'll show you on this next picture right here. This is a oblique flexion. So it's a slight angle so we can see it better. Over here in this diagram, it says capsular ligament damage, and that capsule, it's showing that it's torn open in the back. The spinous processes are flaring apart with flexion, but it's bending too much at that level. And these arrows are denoting that there's too big of a gap happening in between those facet joints. So this is a way of documenting and figuring out, is there facet capsular ligament damage? All right, so on digital motion x-ray or an oblique flexion, which most of the time, no one really out there is taking oblique flexion. Oblique means this. It means essentially at an angle, like close to about like a 40-degree angle, like 30 to 40-degree angle. And then what's happening is you're bending down and back, and you're seeing how those facet joints are opening and closing. The reason we take it at an angle like that is because that's at the orientation of those facet joints. So when you rotate the patient like that and then bend, you're going to see that facet joint much better than if you're at a 90-degree angle like this. Some of the statistics and injury data. Well, the facet joint is responsible for about 20 to 40% of the spinal load. Like I talked about earlier, you have the disc, you have the two facets. It's about 30% each, so 20 to 40%. So there's spinal load happening in those facets. And if there's excessive load, it can cause damage to those facet joints. 55% of chronic neck pain cases are related to the facet. So it's a very important pain generator and cannot be written off. So facets can cause a lot of neck pain, not just the disc, not just the muscles. And then in neck injuries from rear end vehicle collisions, very, very common to have facet joint involvement. 80% of whiplash cases, the facet is the main pain generator. Recovery and treatment. Let's talk about that. So curve correction, posture correction. I'll play a little video here of working on Carly. I'll pause it intermittently. So lift your chin a bit. Good. So right there is a specific adjustment to, that looks like C6, lower cervical spine. If we back that up for a second, and I know we covered this on other videos showing some of the adjusting that we do specifically in Gonstead. There's no rotation. We're not twisting the neck at all. We're just taking that bone and lifting and setting it directly forward, which makes the Gonstead technique very unique, because a lot of the criticism that other doctors or whomever may have who doesn't like chiropractors is they'll say, well, when you twist and you rotate the neck, that can cause a problem. In the Gonstead method, we were never taught to twist or rotate the neck, because we were taught that the main way that the joint misaligns is it shifts backwards and then tips down, as far as in the neck in most cases. So the goal is we're trying to lift and set that bone forward without rotation, without twisting. With that said, the Gonstead adjustment is a more difficult technique to learn. It's probably the reason that most chiropractors do not adjust the spine this way. Instead, they'll lay a patient face up and twist the neck side to side. This is the way that we do it, though. We do it in the seated position or face down. So you can see I'm just pushing straight forward. So lift your chin a bit. And just move straight forward just like that. Okay. So very comfortable. Even when someone's really acute and has a ton of neck pain, we can do this very precisely. And typically it's much less uncomfortable or painful if we had to induce any sort of rotation. Good. Cool. So that was just showing one part of this recovery and treatment, is adjusting the joint, getting the joint that's stuck to move. And then Carly here, she's using this neck exerciser type thing, which basically pulls right there. It creates a fulcrum. She's bending the head side to side, but more importantly, and I don't know if it shows it in this video, she'll be doing flexion and extension. Yeah, so she's kind of like rolling her neck around, but it's more of flexion, extension, lateral bending. So lift your chin a bit. And I'll let it keep playing, so it's going to keep resetting every time I do this, it looks like. So there's adjusting, there's work on the muscles, there's work on just bending the joint, creating that fulcrum. And then she's doing traction. This is spine remodeling traction, trying to load a curve into the spine. So this is distracting, pulling back and up on the neck. And then there's a strap pulling forward that's loading a curve into the spine. And that's set at the exact point that the x-ray shows is appropriate for the specific deformity or abnormality or loss of curve for the patient. So this needs to be guided by x-ray. This right here is showing a pre and post x-ray. So same patient, this is a couple months apart, lost a curve right here, and then more of a curve is restored, not necessarily perfect. We're not looking to hit that green line perfection, which is about a 42-degree curve. We want at least a 30-degree curve in the neck. That's what the research in the literature shows is a really good goal. They show that at least a 20-degree curve can allow someone to have good stability. And on this left x-ray, the starting point, this is a 4-degree curve. So close to 89, 90% loss of curve. That's not a good situation to be in. On this follow-up, this person has a 20-degree curve, which is much improved, moving in the right direction. This is going to have better load distribution on the discs and on the facets. This person's going to have less pain in almost all cases and function much, much better. There have been study upon study that talk about the importance of the curve. When there is a good cervical curve in place, the joints will actually last longer. The rate of degeneration goes down. The rate of nerve issues, nerve involvement goes down. Pain typically goes down. This is not just something that we're doing to try to make someone look a certain way, but it's to directly affect function and long-term health outcomes. Medical pain treatment is usually injections and nerve ablation. Nerve ablation is like burning the nerve. So they may go in and do these guided injections. So it's X-ray guided, and they put this needle right into the facet, and they can put various anti-inflammatory substances into that facet capsule to try to decrease inflammation and pain. And nerve ablation, they would go in and they would burn those little nerves that come off of there so that the brain doesn't pick up that signal any longer. But as you can imagine, that's not really affecting the root cause. It's not really addressing the root cause of the problem. And then something that's more of a regenerative approach. This is not necessarily just pain numbing, but something called prolotherapy, which is like a dextrose sugar type solution that they inject specifically into the facet joints to try to create an inflammatory response to promote collagen formation. So essentially trying to trigger your body to start healing that area to create some stiffness and rigidity around those joints if there's potentially a stretch or laxity or excessive motion in those joints. And then stem cell injections, and this is for cervical cranial instability. And this PICL approach, that's something we covered in a previous video, for example, is done at the Centeno Schultz Clinic up in Colorado, where they do this even with the upper neck at C1, C2, and they go through the mouth to be able to get into those ligaments. So these are not non-invasive approaches. They're definitely invasive. They're just not as invasive as a surgical fusion, for example, which a lot of those are done when maybe some of these less invasive approaches would be helpful, or even the least invasive approaches like what we do would be helpful. But in some cases, people do need surgery. So the important thing is to make sure that you are going to a qualified practitioner that's going to diagnose you properly and give you the appropriate recommendations. And then you need to do your research and understand things like this so that you don't jump into something that might be irreversible if something less invasive could have been a good solution for you. This is showing in the upper cervical spine. This is the injection route. So that's showing like in the PICL approach at the Centeno Schultz Clinic. This is the needle shown injecting contrast and then stem cells into the damaged ligaments. This is something that we covered in the previous presentation when we were talking about upper cervical instability and the stem cell injection route up there. So a more invasive approach would be an anterior cervical fusion, which is called an ACDF. Anterior cervical discectomy and fusion. Discectomy means they are removing the disc. So this is the front of the spine. This is the nerve. The spinal cord's back in here. These joints here are the facet joints, facet joint. Back over here is the spinous process. That's where if you would touch back of your neck, that's where you feel that bony prominence. So this is up by the throat, and they essentially cut through the front. They have to go in, move the trachea and esophagus out of the way, and then dissect down through the muscles to the disc, cut the disc out, get all the way back behind the disc into the spinal canal where the spinal cord goes and the intervertebral foramen where those spinal nerves go, clean out the area to get pressure off of the nerve. Then you're left with this unstable segment. So then they will put a plate in the front and fuse. And then in certain cases, they may do multiple levels. So there might be more than one level involved. They then have to put this spacer in there, and the spacer is usually packed with either bone from the patient or cadaver bone. The goal is not to have this little plate in the front actually hold things in place. The plate just holds this in place long enough so that this spacer with that bony fragment placed inside of it can actually fuse from one bone to the next. So the goal of this is a fusion, so this doesn't move anymore. And like we talked about earlier, that can fix this problem, but it can cause a problem above and below, because now you can have what's called adjacent joint disease, because these other joints are going to have to move excessively and they're going to wear out prematurely. There you have it. We just covered facet and bony changes and how this plays a role in understanding your neck pain. Please share this video with friends, family members, loved ones. This series was created so that you would have as much knowledge on this topic as possible so you could ultimately get to the root cause of understanding your neck pain. So please do us a favor. If you found this video helpful, like the video, comment below, subscribe to our channel. If you want to get a workup of your neck and see if you're a candidate for some of these unique things that we do in our clinic, our information will will be listed below. You can reach out. We'd be happy to connect with you and see if we can help. And when it comes to the health of you and your family, results matter most. Video presentation by Meridian Gonstead Spine and Wellness of Meridian, Idaho. Our practice is dedicated to people suffering from neck pain, low back pain, tension headaches, migraine headaches, herniated discs, and leg pain such as sciatic. We have treatment protocols for musculoskeletal aches and pains, joint pain and dysfunction, and whiplash injury. Gonstead Spine and Wellness offers a distinctive chiropractic experience. It is the only office in Idaho with digital motion X-ray technology. And this advanced imaging tool, combined with the Gonstead spinal analysis and necessary radiographs, enables precise identification of spinal issues. We provide safe and effective Gonstead adjustments, corrective care through chiropractic biophysics to enhance and sustain proper posture, and a 12-week transformation program. This program includes access to a comprehensive video exercise library for ongoing home support, ensuring long-term health and wellness. Call us at 208-888-6077, where results matter most.